Good day, sir. I am Mary Gracie CABO from BSN-1A, and I am going to report about health belief models. First, we have the learning outcomes. So at the end of the lesson, the students will be able to explain the definition of health belief models. Second, identify the 5 stages of health belief model. Third, know the difference between health locus of control model and Rosenstock's and Becker's model. And lastly, analyzing the Rosenstock health belief model.
The health belief model, or HBM, hypothesizes the health-related behavior depends on a combination of several factors, namely perceived susceptibility, perceived severity, perceived benefits, perceived barriers, cues to action, and self-efficacy. Now, perceived susceptibility refers to an individual's opinion of the chances of contracting the illness condition. Now,
for example, a family history of a certain disorder such as diabetes or heart disease may make the individual feel at increased risk. Awareness of personal high-risk lifestyle behaviors also increases perceived susceptibility.
Second is the perceived severity. Perceived severity refers to an individual's opinion of how serious a condition and its consequences are. Now, the third is the perceived benefits. So it refers to one's belief in the efficacy of the recommended health behavior in reducing the risk of seriousness of the condition. Now, the health belief model, or HBM, is a value expectancy theory and assumes that an individual's behavior is guided by expectations of consequences of adopting new practices.
And we also have 5 stages of health belief model. First, the pre-contemplation, second, contemplation, third, preparation, fourth, action, and lastly, maintenance.
So the next one is the health locus of control. So the health locus of control model is based on Rother's social learning theory. So it proposes that health behaviors are predicted by the extent to which an individual believes they can perform the behavior and that it will be affected. Individuals with an internal locus of control, or LOC, are more likely to take action to manage their symptoms than an individual with more external locus of control who believes their symptoms are a result of chance and looks to other sources such as the doctor to manage their symptoms. Now, the locus of control refers to an individual's perception about the underlying main causes of events in his or her life. However, this model has been tested in a wide range of therapeutic areas with conflicting results. Now, some research suggests that what underlies the internal locus of control is the concept of self as agent. Now, self as agent. The most widely used measure is the multiple health locus of control, or shall we say MHLC scale. According to Walston, 1978, evaluating beliefs about health behaviors in general, and the variance in results might relate to individuals holding different beliefs depending on the situation. Now, a health-related locus of control inventory developed in mid-1970s was derived from social learning theory.
Locus of control is a measurable concept that can be used to predict which people are most likely to change their behavior. Many measurement instruments are available to assess locus of control.
Now, when we say internal, locus of control is the belief that you are in charge of the events that occur in life. Now, while the external, when we say external locus of control, is the belief that chance, fate, or outside forces determine life events. Now, understanding how locus of control is associated with outcomes, in this population may provide a basis for interventions aimed at changing a young patient's locus of control. Now, let's move on to the Rosenstock's health model or HBM. Now next was the Rosenstock's health belief model. It is a theoretical model concerned with health decision making. So the model attempts to explain the conditions under which a person will engage on individual health behaviors such as preventative screenings or seeking treatment for a health condition. That is according to Rosenstock. Now we have the main variables of this. The first is the action is more likely if the person perceives himself to be susceptible to or at risk for that condition.
Next, we have the modifying factors. Factors that modify a person's perceptions include the following. First, the demographic variables. So demographic variables includes age, sex, race, and ethnicity. An infant, for example, does not perceive the importance of healthy diet. An adolescent may perceive peer approval as more important than family approval, and as consequence may participate in hazardous activities or adapt unhealthy eating and sleeping patterns. Second is the social physiological variables. Now, social pressure or influence from peers or other reference groups may encourage preventive health behaviors even when individual motivation is low. Next, or third, is the structural variables. Knowledge about the target disease and prior contact with it are structural variables that are presumed to influence preventive behavior. So the last one is the cues to action. Cues can be either internal or external. Internal cues include feelings or fatigue, uncomfortable symptoms or thoughts about the condition of an ill person who is close.
Single campaign evaluation cannot be validate particular model, but it can compare the veracity of each model with a particular context and provide a template for process-oriented HBM or health belief models research.
That would be all. Thank you.